Good morning. Now we're going to move on to something different, at least for me. So my practice has really kind of devolved into two major diagnoses I treat. One is the orthokyphosis, and the other one is the Prader-Willi. So I thought I'd spend a little time talking about Prader-Willi. So it's a genetic syndrome, affects chromosome 15, and essentially the chromosomal material in a very particular neighborhood is missing on the father's chromosome. And it can happen in three ways. You can actually have that this little area is deleted. We call those deletions. You can have two chromosome 15s coming from the mother. What actually happened is right around here there was a trisomy 15, but dad's chromosome got kicked out, and that's why you'll have what's called uniparental disomy. You have two chromosomes from mom and none from dad. Or you can actually just have this Prader-Willi neighborhood here where the methylation doesn't work on. Methylation is, of course, the switch that turns on and off genes. What's fascinating about this is that if you have the material lacking from the mother in this exact same area, with these mechanisms, you end up with something completely different called Angelman syndrome. Prader-Willi occurs somewhere between 1 in 10,000 to 1 in 20,000, and it's the most common genetic obesity syndrome, as you can see here. The other things that you find with them is that they're very hypotonic as babies, and nowadays at least the intensive care units are starting to understand that if you have a very hypotonic baby who doesn't feed, who may need respiratory support, that you should look out for or check for Prader-Willi syndrome. They have hypogonadism, strabismus, tend to be short-statured, and tend to have short hands and feet. But this has changed a lot since the beginning of using growth hormone treatment for these children. So most of these children should be on growth hormone starting out as infants. And they have an obsessive interest in food and become obese, which occurs someplace between 1 and 6 years of age when they first start with that. And they become amazingly obese if they are not well managed. Their milestones are delayed by 100% on average, so they start walking at about 24 months of age. They have osteopenia, which of course causes frequent fractures, but more importantly for us as bone surgeons, we need good bones to hold on to. They have spine deformities, which we'll be talking about. 10% have hip dysplasia, joint laxity and flat-footedness, and some leg deformities that they can have, although I find that unusual now. Scoliosis, the prevalence is about 40%. And it has a bimodal distribution where 50% of the curves happen before 4 years of age, and then there's another peak that seems to happen around adolescence where the more typical idiopathic scoliosis happens. And 15% of these children will need some more advanced treatments such as surgery. And the complication rates from surgery in the literature are up to over 50%. And the incidence of scoliosis is probably underreported because most of these are parental reports, surveys, and oftentimes people are unaware that the children have scoliosis because the curves can be hidden in the older populations due to their obesity, but also because these curves have less of a rotation to the spine compared to what we're used to in idiopathic kiddos, so they have less of a rib prominence. There was a survey done or a study done now many years ago where they looked at a home for people with Prader-Willi syndrome, 37 patients, and assessed them all for scoliosis, and they found that 36 out of the 37 had curves, and that means 10 degrees or more, so not substantial curves in some cases, but that all adults, all 10 of the adults had some form of scoliosis. So it happens very often. Now, when I talk about hidden curves, you look at this child and you say, okay, a little bit of waist asymmetry, but she's actually hiding nearly a 60-degree curve. Or you look at this young man here, and you say, okay, it looks like I got a curve there also. Well, it's a 100-degree curve. So they can really hide their curves quite well. And then when the small ones, you're talking about the infants who have a 30-degree curve, and the pediatrician has them bend over and say, I see something slight there, I'm not going to worry about it. Like I said, that can be a curve that really should be treated. Doesn't seem that the obesity makes much of a difference in terms of the curve, and we see these curves happening very often before they actually become obese. We think that's mostly the hypotonia that causes the curves in the very young children. The obesity may be adding a little bit, but not much. Unlike idiopathic curves, where females outweigh males by a lot, here it's only 10% more females than males that have curves. And if you get a curve, that doesn't matter if you're male or female, the curves seem to have the same prognosis and progression. So why treat them? Well, obviously, cardiopulmonary compromise is a big thing we worry about in general. But with the Prader-Willi kids, they already have a fair amount of they already have pulmonary insufficiency, including problems with central as well as obstructive sleep apnea. So they need to be very carefully watched for that. So as we talked about, there's kind of a bimodal distribution with these, but we typically talk about infantile, juvenile, and adolescent. So if we think about the infantiles, a lot of these can improve spontaneously, and if we really try to strengthen them up, maybe the smaller curves will go away by themselves. But if they progress, they do progress relentlessly. And again, probably relate to the hypotonia, and the ones that improve are those that are able to get stronger. The juvenile ones, there are some that are picked up in this juvenile period. Question always is, are these just late diagnosed infantile curves? And then the adolescent ones, of course, puberty to maturity, and it is estimated that 20% of those will require surgery. So you have a child like this with a year and a half of age, you can see this real hypotonic way she's sitting. She's kind of collapsing into her curve. And in fact, one of the things I tell the parents of the very young children is, don't try to get them up sitting. We all, as parents, we like to get our kids up sitting. We pull them up to sitting position. Child with Prader-Willi should not be sitting independently until they're actually able to sit well, or else when you kind of pull them up, they will collapse down, and we think this kickstarts a curve. So very similar to what the achondroplasia people are saying with their babies. Don't sit them up before they can do it by themselves, or else they get that gibbous. Here's somebody from the literature, 5-year-old girl with a 78-degree curve after bracing. So these curves can really progress on us. So the treatment for me is, first of all, really making sure that everybody screens children with Prader-Willi syndrome. And I usually say that once they start sitting, I want to get a sitting AP spine radiograph, and I also want to then look at their hips and see what their hips look like. Physical therapy, extremely important. Casting, we'll talk about this at length, as well as bracing and surgery. As far as therapy goes, we want to work on trunk strengthening, a lot of sensory integration. A lot of the physical therapists who see children with Prader-Willi syndrome want them to be good crawlers before they are walkers, so they can really work on their trunk. Interesting thing about children with Prader-Willi syndrome is that unlike most children that develop their trunk strength before their extremity strength, these children actually develop their extremity strength before their trunk strength, which is why crawling seems to help. My motto is get them up walking any way possible and then work on points for style. So I will outfit them with AFOs once they're sitting well and try to do some standing with them. What about casting? Well, casting, in my mind, is an old technique that was reborn, that Min Mehta brought out to the rest of us and really got us interested in it. My casting schedule, under 2 years of age, I will change the cast every 2 months. Between 2 and 3 years of age, I'll change it every 3 months. And over 3 years of age, I'll change it every 4 months. And then we keep casting until we either hit a plateau or we hit our goal. And then we go into bracing. And this is not a child with Prader-Willi syndrome, but it's just someone showing you the rotation of the spine that we get. The reason why we have a rib prominence is because the spine rotates when we have scoliosis, and that's what pushes some of the ribs posterior and the rest of the chest anterior, and this gives us that deformity. And so we're trying to derotate that when we put the cast on. It's not just a lateral move, but also a derotation of the spine. So this is our Risser table that we have in our hospital. This is done under general anesthesia, so we just presented a paper on doing this without general anesthesia, but that seems a little bit tricky for us. Head halter traction and then crisscross traction across, crisscross straps across the pelvis to pull traction from below. I have only done below shoulder casts, which is a little bit of a problem with the people who really stick to the meta technique because they like doing over shoulder, but mine have all been under shoulder because that's what the children will tolerate. And then we put traction on them, we derotate the chest and give lateral pressure to it. So here we have the child up. Here's the traction going around the neck. And you can just barely see our straps here for the crisscross pelvic bands pulling on them. So you can wrap circumferentially, mark where we cut out our belly, overwrap, and then this is kind of our finished product here where we have a nice opening here for the chest and a little peek hole in the back. So since 2008, we had about 37 patients that we had casted. 2/3 of them we have more than 24 months of follow-up. And for me, a criteria for casting is a curve over 25 degrees when they're upright, and we want to have them at least at sitting age. I'll have some of these children that are below sitting age with a significant curve. I will hold off on them as long as I can, even sometimes do bracing to get to sitting age before I start casting them. And then just as an aside, a number of the patients have actually learned to walk in their cast, so it doesn't stop them from walking, meaning that they weren't walking before we casted them and they learned how to walk. Well, measure the curve. Obviously, pre-casting is an upright curve. We'll do something called a traction release. In the operating room, we'll pull traction on them. Once they're under anesthesia, pull traction on them, release them, and get an x-ray just to see how flexible the curve is. Get x-rays in our casts, as well as when we take the casts off to see how things are coming along. And our endpoints, we talk about two. We talk about the cured or the controlled curve. The cured curve is one where we can get the curve under 15 degrees or so, or that we have the curve under 25 degrees for 3 successive casts, which means that we've gotten about as far as we can get, but hopefully we're at a good point now that we can transition to a brace for a year, and after the year, get them out of the brace and let them go from there. The controlled curve are those that we cannot get down low enough. And so these are ones that we figure will probably continue to require treatment and probably even progress over time to something surgical. But the further we can push that in the future, the happier we are. So for me, it's if I can get a curve under 50 degrees, by the time they're 5 years old, I'll put them in a brace and expect that we'll be talking about surgery sometime in the future. Or those curves that are over 50 degrees and the child is over 5 years old, we'll start talking about expandable techniques. When we looked at our patients, the average age we started casting was about 32 months of age. Average number of casts was 8, and the average follow-up was another 38 months after we stopped casting. And so if we look at our categories, we had 7 that were cured, 3 that were controlled, and then there's 13 that were intermediate, meaning that there were 8 that were still having casting done, and another 5 that had discontinued their casting, kind of against my advice, but that was what the family needed to do. So if we look at our 7 cured patients, 6 were uniparental disomy, and 1 was deletion. And our average curve size was 42 degrees. Now, I have here, it's 28 to 80. Now, that 80 is a real outlier. He's the only deletion. He had an 80-degree curve. We got it down to just about nothing here. But he has, since that time, parents had a little trouble with maintaining the brace, and the curve has now progressed. And he's now, I think, 6 or 7. We'll be talking about something surgical in the future for him. But the other 6 have done very well. And that's what their range is if we take that 80-year-old one out, or 80-degree one out. And we got the end curve down to an average of 15 degrees in all these patients. And it took about 6 casts and about a year and a half in bracing altogether. And the follow-up curve at our final follow-up is 18 degrees. So they have gotten, on average, stayed pretty good. These are our 3 controlled ones. These were significant curves. They were able to hold for a period of time, let the children get a lot older before we had to go on to something else. The top one is interesting because this patient actually did very well, but then had a respiratory episode after one of the casting, and they stopped the casting at that point, and the curve went from 48 degrees into something nearly 100 degrees over here. So you see this child here in the brace, and then it just got out of control. And so we went to magic rods. And these 2 other ones also went to magic rods. But we got them to a much older age before we had to do anything, which was what really made this helpful. Like I said, 5 kids discontinued casting, and 3 of them were lost to follow. But the other 2 that we were able to keep an eye on, after about 15 months, the curve only increased 1 degree while in brace. So we, again, were able to postpone anything more significant. So here's an illustrative case of a cured kiddo, 32-degree curve at about a year and a half. There he is in his first cast. Here he's after 4 casts, got down to 14 degrees, put him in his brace. And at follow-up, 2.5 years out of cast, 4 years old, looks pretty good. And in fact, at 8 years of age, little bit of a curve, so I started putting him in a Provident brace just to keep an eye on him. Because one of the things that I don't know is what happens when these kids hit their second peak, the second part of the bimodal curve. Will these curves now start changing on us and start taking off? So here's an 18-month-old girl with deletion. As you can see, she's got a sizable curve. It's 106 degrees. So we started casting her, and the first cast got her down to 54 degrees in the cast. Continued to cast her. Here she is at 2.5 years old, 13 casts out. Curve is at 60 degrees out of cast. Did a total of 18 casts on her, got her more than 4 years out. So she was 5.5 years of age. Kept the curve down in the 60s, and ultimately she went on to magic rods, but now she was nearly 6 years of age before we had to do surgery on her. We did not find any difference between the cured curves and the other groups in terms of gender, whether or not right or left curves were worse, whether or not thoracic or lumbar curves were worse, or even the age that we started casting them. None of those things were predictive for us. What was predictive was the initial curve size. So if the curve was under 43 degrees, then the odds ratio that we could cure the curve was 37 to 1. If the traction release x-ray showed they were nice and flexible, that also was very helpful. Rib vertebral angle difference of less than 31 degrees had an odds ratio of 5. But what it really shows is that we need to diagnose these curves early and get to treating them early. And casting is survival. These are just photos that parents have showed them. The one in the middle there, the family had actually found a place that would make a dry suit so that she could go swimming in with her cast on. And here's another child, 17 months old, the 55-degree curve. After 5 casts in 15 months, we put him to a brace, and here he is. Again, parents made a postcard they sent out to their friends with the 5 casts and the 1 brace, and a much older child now. What about bracing? Well, for me, bracing is for curves that children are too old for casting, and curves are between 20 and 25 degrees, or larger than 20 and 25 degrees. I always inform the parents that I'm not going to make the curve smaller, but I can stop it from getting bigger, hopefully. But it can be difficult to fit on the obese kiddo, so it's very important to have the kiddo stay as slender as possible. But here's an example. Here's a child in 2009 had a 32-degree curve. 4 years later, the curve's gotten 12 degrees larger, but still we were able to maintain it and let the child grow a fair amount more. What about surgery? Well, typically I think of surgery as something that we do when the curve is at least 40 to 50 degrees. But my real criteria that I tell parents is that once the curve has gotten bigger than 50 degrees in a brace, so I know that I can no longer use a brace to temporize, that's when I'll start making real plans for surgery. And obviously the goals of surgery are to align both the coronal curve, but more importantly, the sagittal profile. We want to keep in mind that they have low bone mineral density, so we need to have very strong anchors. And there's a high complication rate. And the complication rate in infections very common. Dr. Ovadia and I were just talking about skin picking with these children. And actually, my first child with Prader-Willi, we'll talk about in a second, caused himself a lot of trouble with skin picking. Anesthesia, very important to realize that these children arouse longer from anesthesia, so oftentimes important to keep them intubated overnight. They have pulmonary issues. They need to have sleep studies before they go to surgery. We need to know if they need to be on CPAP or BiPAP after surgery. And there can be hardware failure and pseudoarthroses, especially with the growing techniques, or again, because of osteopenia, the hardware can pull out of the bone. And we need to keep on educating our colleagues about these special risks for children with Prader-Willi syndrome. I was just saying earlier that my motto in these kiddos is it's not treating a child with scoliosis. It also has this interesting thing called Prader-Willi syndrome. We're actually treating a child with Prader-Willi syndrome who happens to have scoliosis, and we need to make sure everybody understands that. This is from the literature. So they had a 6-year-old child with a 90-degree curve, and they did a very nice procedure here, old-style instrumentation, but got a nice correction. But the problem is, 10 years later, this is a 16-year-old child with the chest the size of a 6-year-old, and this child's going to be in trouble. So here was my first patient with Prader-Willi syndrome. I saw him when he was about 1.5 years of age, did all kinds of bracing I could think of. I know more about the Milwaukee than I want to talk about, but everything failed him. So he got to be 6 years of age with a curve over 100 degrees, and we put what I like to call a non-fusion spinal cementation, or a growth type construct here, where you grab them above, grab them below, and these can slide past each other, and we grew them up with that. And then here he is at 16 years of age. The curve is about 50 degrees, but he's doing well. And at this point, I really couldn't expand him anymore. He was too tight to expand, and so I decided to do is just graduate him. And this is what I started to do with all my growth constructs, where I have a fairly balanced spine. Instead of taking this all out and doing a formal fusion, I'm just going to have faith that everything here has healed itself, has spontaneously fused. And with that in mind, I'm just going to leave this in place. And so far, that has worked out well for me, although who knows what the follow-up will bring me. Now, the vector, of course, was it's lessening in popularity now, but it was a very popular technique. Problem was that with Prader-Willi children, it had a habit of breaking through the ribs very early on, within a few months. And then people go back and try to revise that, and after a couple of times when it didn't work, they go and they would fuse. So I really think that the vector is something that should be avoided with Prader-Willi syndrome. It's very good for a lot of other things, but not Prader-Willi. The magic rods, though, have really revolutionized our treatment here. So here's a 10-year-old 83-degree curve, Put some magic rods in him, got him down to about 55 degrees, and after a few lengthenings, down to 33 degrees. And I got to talk fast now. And it's nice because we don't have to keep on taking back to the operating room to lengthen them out. 10-year-old, 78-degree curve, got her down significantly. She looks a whole lot better. And we're able to kind of lengthen her up. A lot of complications with these. We can talk about that some other time. Fusions are, for me, curves are going to be over 50 degrees at maturity. Want to avoid an anterior approach because the literature tells us they have complications in terms of the chest with that. Pedicle screw instrumentation, remember, these an osteopenic bone. I don't want to go above T3 or better yet T4 if I can help it because of sagittal alignment. Quick case right there. You all know what spinal instrumentation looks like. Preoperatively, they need sleep studies. The ear, nose, and throat doctor needs to see them, see if they have to have their tonsils or adenoids taken out. Anesthesia needs to know that they're going to be a difficult IV access, that they're going to be difficult to arouse from anesthesia, maybe keep them intubated overnight. And the pulmonologist needs to have evaluated them for possible sleep apnea with CPAP or BiPAP. They are hypotonic, poor coughing. The skin picking, I thought this was just a social inconvenience that these kids like to pick their skin. But my first patient actually proved to me this is a much bigger problem because they pick at their incisions and they get their incisions infected and they get their hardware infected. So first time around, I actually had to take his hardware out and start all over again. They have a real irony in that they come out of the operating room usually asking to eat, but they have a delayed ileus. It takes them longer to getting around to being able to eat, to feed. And if you feed them too soon, they'll have a huge distension. They can actually get something called gastroparesis. Their stomach distends so far that the muscle gets overextended and ruptures. And it is a way that these kiddos die. At least yearly, we get a report in the U.S. This is a real problem. The cervico-thoracic kyphosis. They have an exaggerated forward positioning of their head. They like to position out kind of bent forward, even as young children. And we always want to correct that. So this is a child of one of my patients, and you can see how he's given himself this little proximal junctional kyphosis. This is before I realized that I shouldn't go so high. The plumb line, you're all familiar that there is a plumb line that we have to look for. And the point I'm just going to make here is that in Prader-Willi syndrome, this plumb line is different. It's a little bit more forward, and we need to allow them to do that. So if I have my stopping instrumentation here, they have a little area here where they can adjust themselves without pulling away from my instrumentation. Or they will sometimes cause, as again, one of my patients, they cause themselves a distal junctional kyphosis, such as her here. Luckily, she settled out here, hasn't had any pain, and we've done okay with that, so I haven't decided to revise that. But this is the most common reason for patients to be sent to me with complications, is that they have gotten this terrible kyphosis. So you see this child here started having problems. Someone started actually taking apart her instrumentation, and she just went further and further. And this is what she looked like before she came to me, and it was hard for her to keep her face up to look at the horizon. She usually looked down at the floor. We actually had to come up high into her neck to be able to get her corrected. Another young man with a significant distal junctional kyphosis that we had to correct out. So the moral of the story is that we really want to keep them, we don't want to correct out their kyphosis very much. We want to leave them with maybe 50 or 60 degrees of kyphosis. This young lady here is some kind of a growth-friendly device in her, but also the severe kyphosis had a hard time keeping her head up. So we had to come high up with her to get her corrected out and leave with some good thoracic kyphosis. And this young man is still pre-op. I don't know what to do here because he had a number of osteotomies that were done. This is completely fused out before they started taking out their hardware. So he's got this 100 and some degree kyphosis that is now solid, rock solid. He'll need some sort of three-column correction. Growth hormone, quick word about this. I do not stop growth hormone when I'm correcting these kiddos. I leave the growth hormone going, and I find that it can only be helpful. So I just want to thank the group sincerely for inviting me here. I want to thank my host for showing me a wonderful time here in Israel and for all of you being so friendly. It's been real life-changing. Thank you very much.